So, good afternoon. Uh, January 6th, 2017, and we're here at lovely Morningside Ministries for yet again another opportunity for all of us to learn and for all of us to be students. I don't think I can tell you how special I think what they do here, the work that the good folks at Morningside Ministries do to keep us all engaged and knowledgeable and of service. So today's presentation is a wee bit different because it's not germane to geriatrics. It is, however, relevant to anybody that's a human being that's drawn a breath on this planet because the last time I checked, as we go through life, we are going to endure trauma or traumas, and the potential is there for mental health consequences. So the title is incredibly simplistic. It's just in big bold letters, PTSD, post-traumatic stress disorder. I didn't put review or update. This is kind of maybe a primer for all of us, but mostly for me in being asked to do this presentation. I've tried my best to do my homework. I bring just a tiny shred of credibility here. I have another life. I'm a Navy Reserve psychiatrist, 22 years in now, and my last two activations, I've gone one to an inpatient psychiatric unit treating mostly Marines with very incapacitating post-traumatic stress disorder. And then the second activation was at a residential treatment center for 8 weeks, again treating mostly Marines, some Army, that had refractory post-traumatic stress disorder. And I'll just simply say that in those experiences, I'm just mostly a student learning because I think we're all learning about this illness ever since mankind encountered trauma. And having said that, as I drove over this afternoon, I don't know if you've heard the news, but an hour ago, a shooter at the Fort Lauderdale airport killed 5 passengers collecting their baggage and baggage claim. And, you know, this is a daily part of our life now. Hearing about trauma like that. We didn't witness it. We certainly weren't threatened, but it's just common now, isn't it? Trauma. And maybe part of that is our culture, part of it is our technology. I guess the second piece to this is a month ago I had our family changed insurance. I went to see my new doctor, and a lovely nurse practitioner came in and said, "Do you mind if I ask you a few questions?" And I said, "Sure, go ahead." And her first question was, "Are you safe at home? Are you safe at home?" This is 2017. We live in a first world country, first world medicine, high technology. Her first question to me is, "Am I safe at home?" And I applauded her internally because I think she views me as an elder and she wants to make sure I'm not being abused or harmed. And I thought about teasing her and asking if my wife was outside. I might be a little threatened by that, but I didn't say anything like that at all. So post-traumatic stress disorder, the Jesuits taught me to always begin things with history. And the history's rich here. I mean, if you look at the Peloponnesian Wars, you'll find descriptions of PTSD. Shakespeare writes eloquently about it. Lady Percy's soliloquy in Henry V is just a beautiful description of post-traumatic stress disorder. In our country, it began to be described medically after the Civil War, and certainly after World War I, they began to military doctors began to describe PTSD in terms of shell shock or combat neurosis. But believe it or not, it didn't enter the psychiatrist's diagnostic Bible, the DSM, until 1980, when it was formally included in the third version of the Diagnostic and Statistical Manual. And that probably came about because in 1980, the Vietnam War had been concluded for 7 years, and this country was now seeing kind of the sequelae of the returning veterans from that war. So the first time we formally acknowledged post-traumatic stress disorder as a psychiatric diagnosis was 1980. And it was listed then as an anxiety disorder, just like panic attacks, generalized anxiety disorder. Now we're in our 5th edition of the DSM that came out in 2015, and it's been revamped. It's been argued and debated, and actually the arguments continued. It's been changed somewhat. It's been moved out of the anxiety classification, and now it's in its own separate classification called trauma and stress-related disorders. So I think that's maybe a strengthening of its position diagnostically. I think it's also a sign that this condition has more questions than answers, and I also think it's sort of a statement that this is certainly here to stay. So we'll begin with the case study, and excuse me that I read it to you. I hate that when I'm in the audience, but part of the reason I'm reading it is for my benefit. A patient comes in, he's a captain, and this is an appointment. He's a 31-year-old young Army reservist who's now come back from his 3rd deployment to Afghanistan a few months ago. And he tells you, the nurse, that he's having a hard time sleeping, that he's having nightmares, that the content is about horrific combat experiences, and he wakes up in a cold sweat, heart racing, disoriented. On top of that, he notices in the waking day he's more and more irritable with his family members, no threat there, and coworkers, and he's not thinking straight, difficulty concentrating. He's worried. He's less productive at work. Now, this is a civilian job. This is an Army reservist. And now he's starting to pull back. He notices that as well, not just family, but friends, coworkers. He'd always been a social drinker, but now he's drinking much more, many times a week. He wonders if he has PTSD. He desperately wants to get back to feeling normal. Wow. One paragraph, but it kind of sets the stage. So we're going to kind of start out physiologically. Please forgive me, but it's something we all understand, because if you and I decided to take a walk down a trail in the forest, and we turn the corner, and there's a mountain lion, or we'll make this more dramatic, a mama grizzly bear with her 2 cubs about 10 feet from us. Instantaneously, we're going to activate a circuit in our brain, and this circuit has to do with fly or fight. And it happens in less than a millisecond. And this is a normal pathway for our survival and our protection. So we know that there is brain circuitry, and we've got it actually pretty well worked out. We have it worked out chemically. We have it worked out anatomically. We've got some nice tools now with imaging that lets us even further delineate this pathway. But quite simply, when we're stressed, pain circuits are activated. And then the good news, maybe we take off, we hot-foot it from Mama Grizzly Bear, or maybe we've got pepper spray, or a flare, or a loud horn, and Mama Grizzly Bear hot-foots it from us. And after a few minutes, our pulse goes back to normal and we stop sweating, and our blood flow, which has all been kind of sent out to our periphery so we can fight or run, comes back to normal. So after the stressor, the trauma is withdrawn, normally the circuit goes back to just sort of baseline function. That's how we're all built. Everybody here is hardwired that way. But we think it's possible that we can get sensitized. In other words, if we abuse these circuits over and over and over again, think about our Army captain, 3 deployments to a combat theater, that these circuits get sensitized, and maybe the switch kind of stays in the on position. Another metaphor might be if you've ever been at a boring meeting and you happen to be toying with the paper clip, so you bend it a little bit and you bend it back, and it doesn't break, but you bend it and you bend it a little back. But each time you bend it, we're kind of causing an increased perturbation in it. I don't even know what that word means, but it just kind of came to me. And ultimately, if you keep bending it enough, what happens to that? It breaks. So same thing here. If we continuously abuse these circuits, they get sensitized. And maybe it stays stuck. And even though there's no threat, the signals are still going out. Okay? Or it never comes back, maybe maybe it partially restores itself. So what happens is we get a breakdown. And we think, there's a lot of controversy. We think that something like this occurs with post-traumatic stress disorder. Now, I neglected to define post-traumatic stress disorder, but it's kind of evident from just the title. First off, if we're going to have a stress disorder, it has to follow a trauma. That's what this condition is saying. This is the only diagnosis in the Diagnostic and Statistical Manual that actually has a cause, an identifiable cause. You might say, well, wait, doesn't depression have a cause? Well, we have lots of theories, but it's not in the diagnostic description. This is the only diagnosis with the cause. And actually, that trauma piece must be there, or it's something else again. If you want to call it stress, so be it. We've all had stress. My boss yelled at me today. The paper didn't arrive on time. These are stresses, but we're talking about a trauma. And by definition, a trauma is something outside of ordinary human experience. And right away, we can immediately think about it in our 21st century. Combat, clearly outside of ordinary experience. Acts of God, tornadoes, tsunamis, earthquakes, mudslides, fires, catastrophes, multiple motor vehicle accidents, a mugging, rape. These are extraordinary experiences outside the human spectrum. These are traumas. And you might say, well, you're being kind of gentle here. There are other traumas. It sort of depends on the person, but that's kind of the opening salvo in the DSM-5, which is for this condition to be diagnosed, first and foremost, there has to be exposure to a trauma, So here's the circuitry, and we'll kind of pick up the bead here in a minute. This is a kind of a, I don't know, maybe overly descriptive diagram, but this is the circuit we're talking about. And, you know, in medicine, we love to use abbreviations. So this is called the HPA circuit, the hypothalamus, pituitary, adrenal axis. And if you kind of look first at that diagram of a human being, and you begin in the brain, you'll see that the hypothalamus, that's kind of an extension of the brain, has a direct circuitry to the pituitary. And when we round that corner on the forest trail and we see the grizzly bear, instantly an associational area in our brain, the hippocampus, fires a signal to the hypothalamus, and it releases a little chemical there, corticotropin releasing hormone, to the anterior pituitary, and that signals another hormone, the adrenocorticotropic hormone, to these little glands on top of our kidneys called the adrenals that immediately releases adrenaline and cortisol so we can fly or fight. And again, this all happens in a millisecond. So this is the axis that we think gets disordered, dysregulated in post-traumatic stress disorder. So there's a biology to this, okay? And it all begins with exposure to that threat, and that threat usually implies death or serious injury to the person or to someone that they see death or serious injury happening to. So typically it has to do with the patient, but sometimes it can be a visualization. I remember vividly seeing a Marine, and in a combat situation, he just had a horrific image. It was kind of his, it's called index trauma, where his best friend was just horrifically wounded and died right next to him in a trench. And it happened in kind of a 6-hour assault. So they were trapped, no escape, and he wasn't injured, threatened, but he saw his friend die in a very horrific way. So just a little more biology. There's an awful lot of research and awful lot of evidence that suggests that what happens to us very early in life may set the stage for making this axis, this HPA axis, perhaps more vulnerable, like that paperclip that we bend and bend. Or, and this is where it gets a little puzzling, there's some evidence, not as much, that maybe what happens to us very early in life that's stressful might make us more resilient. So it's a little bit puzzling. There's good evidence either way, probably more evidence for making us more vulnerable to traumatic stress. On the right-hand side of this slide, there's some anatomical evidence that this very particular part of our brain called the hippocampus, if it's smaller than usual, that also might make us more vulnerable. What we don't know for certain is if that's a setup before the person's exposed to the trauma, or does the trauma itself have an effect on the hippocampus. So again, we'll all leave this with more questions than answers. And then the last piece is we now know about a chemical in our brain called BDNF, brain-derived neurotrophic factor, that a lot of research scientists call miracle grow for the brain. This appears to confer lots of positive benefits to us mortal humans, but there's mounting evidence that with PTSD, BDNF doesn't go up, doesn't stay the same, it goes down. So you can kind of see that this biological illness has got some underpinnings in early life stress. It's got some underpinnings in anatomy, hippocampal atrophy, and maybe it even has some chemical effects on neurotransmitters in the brain. So what a fascinating condition or illness. So here's a story, early life stress versus resiliency. And I didn't know this until about 15 minutes ago. So here's probably the world's most famous, I'm not going to say woman, maybe the world's most famous human being. I mean, just a remarkable gal. But do you know about her early life? Talk about traumatic. It was extraordinarily traumatic. She underwent rape, as a very little girl. Certainly had multiple trials and tribulations, yet somehow she was able to endure, thrive, prosper, grow, and kind of reach out to others. So, this debate is fascinating. I think probably both sides will be right. The question is, how are they right? So the leading idea is that early life stresses, adverse events set us up for PTSD, but perhaps in some people they make us protected from PTSD. And you might say, well, how can that be? What's is it the right amount of stress? Is it the timing of stress? Does it occur when you're, under 6 or when you're under 10? Well, maybe it can be that way because of genes. Maybe Oprah got dealt the right genes by the hand of God. Okay, there's evidence now that there might be something as a resiliency gene. And, of course, we always like to extrapolate from animal studies about our lives, but this is fascinating. They have these particular, this isn't one, by the way, a learned helplessness task. What's on the slide is a maze, but learned helplessness is, particular situations that they put mice in, and the resilient mice are able to escape pretty quickly, and the helpless mice very quickly become paralyzed and perish, if you will. And when they look at, these two different types of mice, resilient and vulnerable, they're actually able to discover that in a particular part of the brain, the resilient mice are less activated, and this part of the brain, the medial prefrontal cortex, is where we kind of process threat and fearfulness, and also where we can process extinction of threat. So this is interesting. We see that they're different. And we also see that we can take the resilient mice. I mean, that last bullet's kind of stunning. And if we activate this particular area, they now become helpless. Holy cow. What's going on here? Well, back to resiliency and genes. And there's evidence increasing that maybe this NR3C1 gene might confer vulnerability. So if we happen to have been dealt that hand by the Creator, we may be at more of a setup for it. And then, of course, if we have early life stresses and we've got this gene, even worse. Okay. And again, there's evidence that folks with this gene, they tend to have problems with glucocorticoid, that's that release of that sort of stress chemical. They overexpress it. They overexpress it at the wrong time. And maybe that's where that switch starts to become broken and doesn't respond. So all this language kind of funnels down to some of us are vulnerable to PTSD and some of us aren't. You might say, well, that's good news. You know, we think in terms of military combat. Of course, we know that the figures now are stunning, you know, hundreds of thousands of Iraq, Afghani vets that are being diagnosed and meet criteria for this illness. But the good news is it looks like the point prevalence for PTSD, combat-related PTSD, is maybe 1 in 7. So that means 6 out of 7, they'll endure these horrific traumas, maybe repeatedly, maybe multiple deployments, and they won't be stricken. So not everyone has this condition. Maybe the folks that are genetically vulnerable, maybe the folks that have early life stressors, maybe the folks that have different circuitry. So that was probably way too long and way more than you'd want to know, because what we want to know is, how do I know if it's post-traumatic stress disorder? So this was actually, I think, about 4 or 5 slides, but the wonderful group that I have the privilege to work with, they said, let's just get to the basics. So number 1, we've got to have exposure to a life-threatening or serious injury trauma. And then number 2, after this trauma has passed, and typically, you know, you ask the patient, in your lifetime, have you ever been exposed to any experience where you thought you might be killed or seriously injured, or you saw someone killed or seriously injured? Maybe you're a little kid and you watch your friend get hit by a car and then they die. So that's question 1, exposure. Question 2, during this event, did you respond with intense fearfulness, horror, or helplessness? Okay. And then question 3 goes right to bullet B. Have you re-experienced this event in any way, typically nightmares or flashbacks, since it occurred? So right away, these are sort of the hallmarks, the beginning hallmarks of PTSD. And then you can imagine if this has happened to you, you know, and you're re-experiencing it with flashbacks in the day. They're unwanted, they're intrusive, they're powerful. You know, you're seeing it all over again. Or nightmares at night. You can imagine if that's coming to pass, that after a while, you know, you're starting to pull back. What's going on? What's happening to me? You know, I don't want to be around other people, places, or things. Maybe I'll re-experience this again, another trauma. So there's this incredible avoidance and numbing and detachment. And then the last piece about PTSD is there's this hypervigilance. I'm now on guard all the time. So I'm having trouble sleeping. I'm scanning, okay? I'm terrified that something like this, some threat like this, might happen again. In other words, nothing's safe. Nothing's safe. We have some screens, you know, medicine loves to have all sorts of tools to diagnose. What we don't have is a biomarker. So it's wonderful to live in a first world medicine country where if a patient comes in and says, you know, I've gained weight and I actually haven't been eating very much and I'm thirsty all the time and I'm urinating all the time. So right away the clinician is thinking, sure sounds like diabetes. So we can draw their blood right then and there. We can look at their fasting blood sugar. We can look at a measurement in the blood called hemoglobin A1C and diagnose diabetes. It's wonderful. We don't have a biomarker for PTSD. Got some ideas, but nothing that we can do in the office. We don't have an imaging for it. You know, if you have Parkinson's disease, we can do a special type of scan and diagnose Parkinson's disease. We don't have an imaging marker for it, although we've got some ideas about that. So this is a diagnosis that's by history and examination. And these are some tools that we use. This first one is just a screening tool. There's only 4 questions, and I already gave you 2 of the 4 questions. The second one is the one that's favored by the military, by the Department of Defense. This is sort of their gold standard. As you can see, it's 19 items that have to do in great detail with those kind of umbrella symptoms that we talked about. And you can see that it's scored from 0 to 4. So if someone reports severe symptoms on all 19, let's see, what is that, 68? Am I doing my math right? So cutoff score to make the diagnosis of PTSD is 50. And then there's a variety of other tools. So these are just assessment tools. They're screens. They're not diagnostic, okay? But let's kind of back up and look at another case, and you can kind of match up. Remember our pieces. So trauma exposure, re-experiencing, avoidance, arousal. So here's a 29-year-old young vet, comes into the emergency room. He's having headaches and pain in his upper quadrant. He's been discharged after he suffered a blast injury in Iraq. His right arm had been blown off then, and he's an amputee. Since discharge, he gets care at the VA, but he stopped going because he didn't think they were taking care of his pain. Said he had no pain medicine and couldn't sleep. Said, I'm scared I'm going to hurt my family if I don't get this pain under control. So the VA wanted to find out about whether or not he was, following protocol with strong pain medicines. And, they were concerned that maybe he was abusing his pain medicines. They discovered he'd been getting treatment for PTSD. He'd also been getting treatment for traumatic brain injury. That's where someone suffers a closed head injury with loss of consciousness. And he's not thinking straight, and his memory's not as good as it was. As they kind of talk to this gentleman more and more, he talks about using alcohol to intoxication every night to self-medicate his pain and his trauma. Before he went in the military, he had a history of aggressive behavior. Kind of makes you wonder about early life adversities, okay? Because of concerns about domestic violence, the emergency room social worker makes a call with the patient's permission to talk to his spouse to see if she's safe. She says, he's not laid a hand on me, doesn't think he would harm her or her children, but she's really worried about her husband. Served his country, lost his arm, suffering now. And she says he's having frequent nightmares and horrific pain. So, I mean, you just listen to this and you can feel this. And I mean, there's a lot going on for this poor soul. And it all began. It all began with this blast injury and loss of his arm. And he's getting treatment, but the treatment's gone off the rails. Resurrection here, we got to come to some good news, okay? So the good news is that here's this condition that's been around certainly since man encountered trauma and, kind of really identified and got a lot of publicity with military combat, but certainly PTSD extends far beyond that. There's actually kind of separate domains for what they call rape trauma syndrome, for abuse of and or torture of young children or adolescents. I think that was just on the news last week in San Antonio, Texas. So treatment for post-traumatic stress disorder. This is in evolution, in transition, but the good news is the first recommendation, and this will sound unusual for 2017, where we always want to lead with a pill, but for PTSD we want to lead with psychotherapy, translate that to talk therapy. And these are very specific types of therapy. The first one is called exposure therapy, where you actually ask the patient, in a safe place with a skillful therapist, to begin to recount the trauma and process it in a different way. It sounds difficult because it is difficult, but what they're trying to do here is restore that circuit. So this is first line treatment. Second line treatment, very strange thing. It says EMDR, eye movement desensitization and reprocessing. This has been around since 1992. It's exactly what it sounds like. This is done again with a trained therapist. And it's an interesting concept, which is these thoughts that are almost inescapable, about reliving the trauma. If there's some way to distract from them, then they're less destructive to the patient. And one way to do that is these patients are taught particular eye movements to cues and signals. And if you're taught to do that, you might even play with it here in the audience. If you're moving your eyes right, left, up, down, you'll notice it's kind of difficult to concentrate on what I'm saying fully and on what you're thinking. So this is a technique that's taught to the patient. So stress inoculation, this is really in its infancy, but can we take basic trainees and somehow inoculate them emotionally to what they're about to face? I think it's a nice idea on the surface, but I think combat is not something organized or rational or predictable. It's chaotic, it's irrational, so I think it's a nice idea, and that's why you watch basic training where they're crawling under a machine gun that's firing. Well, that's lovely, but they know it's not a real threat, but there's some benefit to that. You'll notice at the bottom, although these are starting to get more and more traction, Eastern therapies, meditation, yoga, mindfulness, another way to kind of reset this circuit, because we know that when people practice these techniques, they activate a different circuit in the brain that's it's called the parasympathetic nervous system, that is what we notice when we're calm and at peace. Do we have medicines for PTSD? We have two that are approved by the FDA, Paxil, that's paroxetine, and Zoloft, sertraline. There's a third medicine, venlafaxine, Effexor, that's got pretty good evidence. So these medicines are antidepressants. And as you might imagine with PTSD, if you are re-experiencing trauma and you become avoidant and you're hypervigilant, it's a safe guess to say that you've got significant depression, because your life is not upside down, it's underground, okay? So there's a tremendous comorbidity with depression, and these are antidepressants, and they're useful. Second line, you'll notice that little signal. I always wonder what that is in my car, and my wife tells me that means my tires are low, but that little signal with the exclamation point. So these are other medicines, but that fourth one, benzodiazepines, I need to put a big X on that. These are anti-anxiety medicines. Sounds like they'd be helpful for people that are anxious and worried and terrified. They actually make things much worse. And they're very easy to abuse. And you remember our last case study, this poor amputee is drinking himself to oblivion and to relieve his pain and relieve his nightmares. So there's another addictive substance that now complicates treatment. Lots of other medicines that look like they might be useful. They all have their pros and cons. And then the last one is a real surprise, but I can endorse its benefits. Prazosin is not a psychiatric medicine. It's a blood pressure medicine. It's called Minipress. Maybe you know someone that's taken it or that uses it. And these folks suffer really horrific, wake you out of your sleep in a cold sweat, terrifying nightmares. And this blood pressure medicine remarkably helps with restoring normal sleep. It's been pretty well studied, although dose remains variable. It's got some side effects, but it's used in abundance in the Department of Defense for nightmares and sleep, and works very well and is not abusable. There's a ton of investigational treatments, more and more every day. Some folks wonder if we can stop PTSD if we can get to the person that's been exposed to the trauma within the golden hours, which is 6 hours after the trauma, kind of like the golden minutes after a stroke. If you can get somebody that has a stroke and evolution within, an hour or two and give them an anti-clotting agent, you can prevent the consequences of the stroke. So there's some questions, and actually there's some evidence that if you can give someone that's experienced a horrific trauma within 6 hours hydrocortisone, or a beta blocker like intravenous propranolol, and sometimes you can do this. For example, a terrible car wreck, someone witnesses it, they're in the emergency room, the ER doctor can give them a bolus of propranolol or hydrocortisone. It seems to prevent that circuit from getting stuck. So it's kind of a preventive piece, sort of fascinating. That second bullet, you say, oh, MDMA, I've heard about that. That's an illegal drug, okay? This is the drug in the 70s called the love drug. Actually, just last week, it's been approved for experimental use by the FDA. It looks like it's got remarkable effects at extinguishing this sort of ongoing fear response. So here's an old outlawed illicit recreational drug. That's a lot of adjectives. That's now being looked at in a new way to try and help people with this condition. Ketamine, this is a dissociative anesthetic. There's some evidence that it might be useful in people that have serious, severe depression that doesn't respond to anything else. So this might be useful. Dextromethorphan, you say, that's a cough syrup, isn't it? It is. But it's got some unique mechanisms in the brain. It's somewhat ketamine-like, so that's being looked at. And then the last one is actually an FDA-approved medicine. Quetiapine is Seroquel. It's an antipsychotic. It's been around since 1990, and a very nice study just done that indicates it's pretty helpful as a medicine. We've got some devices now to help kind of improve or restore circuitry and neurotransmitters. That first one, it's a real mouthful, transcranial magnetic stimulation. There's actually a picture of it occurring there in the slide. It's painless, it's done in the office. It's a very focused beam of magnetic energy at a particular part of the brain. It's kind of laborious. You have to have a treatment every day, 5 days a week. It takes about a half hour for 6 weeks. But it's got some remarkable benefits in depression and anxiety, and there's some evidence that it may be useful in PTSD. The second bullet, these are direct current stimulation, alternating current stimulation. These are things that people can actually do at home, but the evidence is fairly weak. They're kind of handheld devices, strangely enough. And then neurofeedback, again, iffy, but I put them here just to kind of say there's more than hope. There's an energy here because this illness is legitimate. It's real. We've got a huge population, and I suspect we'll have a never-ending population until there's peace on earth here. I didn't mention this because I didn't want to demoralize you further, but those case studies already gave you a very strong hint. Because of this illness and the way it presents and the way it kind of haunts people, there's unbelievable comorbidities. So they don't just have PTSD, they've got substance dependence, whether it's alcohol or drugs. They've got chronic pain, because typically, particularly for folks in vehicular accidents or in military combat, they've sustained blast injuries or wounds. Traumatic brain injury, we know that single diagnosis, TBI, comes with a multitude of presentations, not just difficulty thinking, but pronounced apathy or significant disinhibition, inappropriateness, attention problems. So, this is an illness that just has lots and lots of baggage with other conditions. It's not one single thing that we're trying to treat, and that's what makes PTSD, I think, very challenging, very complex. I don't think there's going to be a single bullet or a single therapy, and more to come. So, just some simple take-homes. The good news, an awful lot of us in our lifetime will have a traumatic event, but most of us will have what they call an acute stress disorder, but they fade after a couple weeks or a month. With PTSD, it only accelerates out a month afterward. So complex piece, we know that there's certainly environmental triggers, there's genetic predisposition that may be predictive. Maybe in the distant future we'll draw our blood, we'll know whether we're genetically vulnerable to it. Maybe we'll be able to have interventions to prevent early life adversities as best as humanly possible. Maybe we'll have kind of on the scene chemical interventions that will prevent this circuit from starting up. I can go on and on about the future that I pray for, but I guess maybe the summary is it's complicated. And then the last piece, I think the case studies said this better than anything else. These disorders truly wreck people's, not just the patient's life, but their families. I remember vividly in the residential treatment center, a fellow who, I think he was on his fourth or fifth marriage. None of them lasted very long, and just had left this incredible wake of chaos because of this illness. So these patients truly deserve, good diagnosis and the best treatment that we can provide and create.
Anesthesia.
They still do.
Do they?
They use it at SAMC in the burn unit.
I was going to say, the burn unit used ketamine all the time.
It's a dissociative anesthetic, so when they would debride patients, to graft them, they'd give them ketamine. But so that's typically like a standard adult, they'd give them 300 milligrams of intravenous ketamine for anesthetic purposes. For depression and for PTSD, they get 20 milligrams, slow push IV over about 2 hours. And that's where they see the benefit. So it's a different dosing, and they don't dissociate, if at all, with that dose. Unlike and I mean, there's some value to dissociating if your
Right.
wound's being debrided.
Right.
But that's also the other part about ketamine. Sometimes people dissociate to where it's not at all pleasant. So your memory's spot on, and it's still being used. And in fact, if you lacerate your leg and you go to the emergency room, they might use some ketamine quickly, low dose, quickly to suture you up if they can't get local anesthesia. So it's used in ERs to a degree as well.
Interesting.
So your memory is exactly right, and it's still around. Well, that already exists now. So you are astute. So we see PTSD now in drone operators that are sitting in a shack in Nevada. And of course, the armed drone has a camera, and they follow it down until it impacts. So they see the person they're about to kill, 10,000 miles away. And they also see the collateral damage that occurs. So those folks have PTSD because they're witnessing trauma.
Never mind
Yeah, so, right, is
that. New forms.
just because we get more distant from what we're doing doesn't necessarily mean we don't experience trauma. Nice idea, but I don't know that's so. Boy, I think you spoke a profundity there. It's the type of trauma. There's good evidence that the trauma where you're trapped, and maybe when you're little and a trauma occurs, you're not trapped. It's a bad thing that's happened, but you're not trapped. Trauma that is repeated and endless, like a firefight for 6 hours. Boy, the folks that had PTSD the worst are the ones that are on deployment number 6, okay? So it's like inescapable. So trapped, inescapable, violent, as opposed to more an act of nature or an accident. I mean, that's something we can kind of rationalize. But the violent, inescapable, trapped, out of our control trauma, that's has much more impact. So I think we're probably, maybe in the future, we'll kind of delineate not just exposure to the trauma, but the type of trauma, But you're right on the money. I wish I could answer it better, but so yeah, I believe you that we survive, we endure. Maybe we reprocess it and use it in a healthier way. That's part of the talk therapy piece. But how do you reprocess irrational, insane conflict where that's the other part I left out. The Jesuits would be really mad at me. So the one thing I did not see coming in working with the last group of folks is so they're terribly broken emotionally. They've got a lot of physical injuries because they've been blown up in the air and they've broken their hip. They've been wounded, so they've got a lot of physical pain. But what they also have is they have moral injury because they have seen and done things, not once, but many times, that in a Judeo-Christian culture we are not to even comprehend or think about. And they didn't want to do it, but they had to do it. So, there is a component that medicine isn't going to touch. Talk therapy won't touch, but at this treatment center we had a chaplain that had 3 deployments to Iraq. They had group therapy with the chaplain about moral injury. That's all they talked about. Then they had individual therapy. That was twice a week. And then once a week they had individual therapy where the only topic was moral injury, trying to recover from that piece. So that's that's another part that's not in as a child I suffered this trauma, but it wasn't a moral injury. And I mean, that's something that's just beyond the ken. So we got in with the story, and I was going to use the story at the beginning, but I wasn't sure if it was appropriate or not, but I got in with this because I just think it's timely. So you heard about mischievous Roberto, 10-year-old boy, and he was always in trouble, and Christmas was coming, and he really wanted a bicycle, and he said to his mom, "Do you think Santa will bring me a bicycle?" And she said, "Well, the way you've been behaving, I'm not so sure." She said, "Why don't you write a letter to baby Jesus and see what he can do?" So Roberto sits down with a piece of paper. He goes, "Dear baby Jesus, I have been a very good boy." Crinkles it up, throws it in the garbage can. Gets another piece of paper. He starts writing. He goes, "Dear baby Jesus, I have been a good boy." Yeah, that's not going to work. He kind of looks up, and there on the mantle is a statue of the Virgin Mary. So Roberto's eyes get real big. He goes in the bathroom. He gets a big towel, and he grabs the statue. He wraps it up in the towel. He goes into his bedroom, goes into the closet. And he puts the Virgin Mary statue wrapped in the towel underneath a bunch of shoes and toys. And then he goes back out and he gets a letter. He writes, "Dear baby Jesus, if you want to see your mother again..." I shouldn't have led with that, should I? So that's the trauma. He's kidnapped the Blessed Mother, okay? But we'll just leave it at that. Should I lead with that? I don't know. I got to tell you that at the end, because this is a tough lecture. It's a cute little story. Somehow I can believe it. Well, thanks for coming on I don't know how cold it is out there, but in Chicago it's a summer day, so